Well, thanks everyone for joining us this afternoon in this fourth in the series. So that's the weeks are passing on. That's for sure. We have lots of lots of interesting and exciting things to discuss today. But first, I'll give you a little warning. Uh, just to suggest that the information that we're presenting can improve your health so quickly that you might need to discuss how your health is changing with your doctor. So Eric from Ottawa didn't mind sharing some information that he's gotten a little bit of inspiration in the kitchen, uh, and his blood pressure started out around 128/80 on medication, which isn't too bad at all for somebody over 40. In just a few weeks now, he's only on a quarter of that dosage, and his blood pressure is now 114/71. So that's just an example of how quickly, just in a few weeks, uh, one can dramatically improve their health. So, what are the topics today? The main topic we're going to discuss is obesity and the COVID-19. We'll also explore why the bigger picture of obesity and weight challenges, why it's so hard to lose weight, why also at the same time, I think the important message, why it's so easy to lose weight. Hard and easy at the same time, and we'll talk about that. And of course, key strategies that we need to optimize nutrition to achieve a healthy weight. And stay tuned for the very end with a great new recipe. In fact, this recipe, I tried it for the first time last night. It was a big hit in our house. The rest of the crew here gave me the 2 thumbs up. So I'll give it the 2 thumbs up to share with everyone. And also, we have a special guest today, Dr. Chris Milburn, who is going to join us to offer his insights into the COVID-19, give us an update on the situation here in Cape Breton and eastern part of Nova Scotia, as well as the whole province, and talk a little bit about obesity in that context. And I'll try not to talk too much myself today and leave some extra time for questions. Please type your questions into the chat box, and Nancy can relay them to Chris and myself. Okay, so thanks a lot. Let me just say once again, before we give Chris a chance to offer some input, recall that certain comorbidities are associated with the worst outcome from the SARS-CoV-2 virus. Older people, to a great extent, but very much connected to these comorbidities: high blood pressure, cardiovascular disease, diabetes, and of course obesity, which is getting a lot of attention in the last few weeks. And in the earlier part of this series, I talked about how the dysfunction of the endothelium, the inner lining of our blood vessels, and the ability to produce nitric oxide appears to be a key strategy to think about improving our health in response to the virus. And green leafy vegetable therapy, one of the most valuable things to focus on nutritionally. Trying to eat them 6 times a day. There was our list. You can review that in previous webinars on YouTube. Okay, obesity, maybe we can give Chris a chance for some input at this point. Chris, are you there?
Yeah. Okay. So I'll kind of, I wanted to talk a little bit about COVID and some basic data and stats and where things have gone over the last few months with it. Because I think there's a lot of misinformation out there. I still see people, my wife and I were out for a walk the other day, and somebody was coming down towards us on the sidewalk. We were going to move over to the side, but before we could do that, this woman who looked pretty young and healthy crossed the street to the other sidewalk and pulled her bandana up around her mouth and looked very, very concerned. And I certainly meet I meet people who are in that state of mind at the hospital every day. And I kind of want to put the risks in perspective for people. So the first thing I'll say, like, just going back a bit in the history of it, when this first hit in China, nobody knows what to make of China because obviously it's a dictatorship and the information out of there is not reliable. So we don't really know what to make of the data. Did 3,500 people die, or was it 30,000? And how dangerous was it really? We don't know. But then it went to Italy, which is a fairly modern country and much more open in terms of its press. And the first reports out of there were absolutely disastrous. There were all these videos and pictures of overwhelmed hospitals and morgues overflowing and people, more or less dying in the streets. And it sounded like the Black Plague. And they were saying that the case fatality ratio was something like 12% or 13%. And that's a really frightening disease, one that overwhelms your healthcare system and gives you 1 in 10 or more chance of dying. So we were understandably pretty nervous here, and the healthcare system immediately went into preparation mode. We emptied out the hospitals. The hospitals in Nova Scotia and right across Canada in general are as emptier than they've ever been, certainly in the last 50 years. We made space in our ICUs. We made space on the wards for all these sick patients that we felt were inevitable. And we went into this hard lockdown. And as folks know, wherever you are in Canada, it's not turned out to be nearly as bad as we thought. Quebec, Ontario, BC, Alberta have had a little more problem, but especially for us in the Maritimes, it really just hasn't panned out to be a big issue. Right now, we have spots for, I believe it's somewhere well over 200 people with COVID. We've made spaces for well over 200 people with COVID in Nova Scotia. And as of today, last I saw, we had 5 people in the hospital. So we have all these kind of empty beds and people, nurses and doctors currently paid to look after empty wards. And that's, in general, the rule right across the country as well. So things have surprised us. What do we know? Well, anybody who's followed the news in Nova Scotia, or again, Ontario, in Ontario, for instance, they have over 1,500 deaths at this point, but slightly less than 5% of the deaths are under age 60. So 95% of the deaths are over age 60. And I believe it's about 65% of those, 65% of the total deaths are actually over age 80. And well over half the deaths are people in nursing homes. So this isn't hitting young, healthy people. In fact, in terms of what we call an infection fatality ratio, i.e. if you get the disease, do you die? It's actually less dangerous for young, healthy people than a regular seasonal influenza. But it seems to be at least slightly more dangerous than an average influenza for the old folks or folks with what we call comorbidities, which Mike listed below. So we have definitely seen that this disease in Nova Scotia, it's almost 100% people who've died of being in nursing homes, and every one of them has been quite elderly and very unwell. So we haven't yet lost any young, well people here. Statistically, it will happen at some point in the next year or 2 or however long this lasts, but it hasn't yet. So that gives me a chance to swing back around to what are the risk factors and what can we do about them? Well, Mike had listed them, but obesity, smoking history, diabetes, cardiovascular disease, hypertension. These are the things that seem to predict whether somebody's going to do badly with coronavirus if they do get it. Why would obesity be there? It seems like something that it's a bit of a strange risk factor. But firstly, it's not well understood why, but we know that it is a risk factor, and probably about you double your risk for dying or being seriously ill from coronavirus if you're overweight or obese. That's a pretty significant difference. It probably partly because it's related to other things. So most people who are obese probably don't have healthy coronary arteries. If you could look in everybody's arteries, most of them don't have normal blood sugar regulation, even if they're not officially diabetic yet. They're probably not well regulated in terms of blood sugar, so they have some of these other risk factors. The other thing that I think is really important to understand about obesity, a lot of people look at obesity as a mechanical problem. Well, if I have extra weight on me, it's on my joints, it's weighing me down, it makes it harder to move. But they look at it as sort of a mechanical problem, like having a heavy backpack on. But that's a really overly simplistic way of looking at it, because fat tissue is what's called metabolically active. It doesn't just sit there like a lump of steel in a backpack. It actually produces all kinds of hormones and chemical signals in your body, which change your blood pressure, damage your arteries, change your blood sugar, and do all these other hormonal things, and increase the risk of cancers and whatnot because of their hormonal effects. So it's a metabolically active tissue. It's not benign. There is also one mechanical reason why people who are obese probably do worse with coronavirus. There is a mechanical effect, even with relatively small amounts of overweight. So for instance, somebody's only 5 or 10 pounds overweight. When you measure where that is, even if they don't look fat, a lot of that is it's called visceral fat. It's stored in the abdomen. And what that does is it actually pushes up and it reduces the lung volume. So somebody who is overweight or obese has reduced lung volume for their body size. And that means that anything that reduces the efficiency of the lungs' abilities to take up oxygen and get rid of CO2 affects them more. They need all that lung tissue working because there's less of it. And number one, they have more body to feed with oxygen and to get rid of CO2. So they're more delicate balance, and they don't do as well when they do get ill with lung infections. We've also known for some time that people who are obese have a significantly increased risk of asthma and other wheezing disorders. And again, that's probably a hormonal effect, not well understood, but that probably plays into why they do worse with coronavirus as well. So there's a number of effects of obesity that make it completely logical that these people would be a lot more at risk from coronavirus. So with that, Michael, Peter, unless I missed anything there, I'll pass back to you.
Thanks, Chris. Thanks for those insights, which are important to share. Let me just explore a little bit the broader context of the obesity problem and see if we can see if that leads us to some solutions, which I think is the key thing at the end of the day. So really, since the 1970s, the extent of obesity in many countries and now globally has really taken off. We can talk about obesity both in terms of the body mass index, but also the waist size. As Chris mentioned, the visceral fat inside the abdomen is often one of the worst places to hold fat. So if we actually look at the data in different countries around the world, we see quite an interesting direction of the curve. Everything's headed upwards. United States leads the pack, of course. Canada, England, Mexico close behind. Some of the European countries a little bit behind the pack, but catching up in the race. Even amongst children and adolescents as well, it's been something that's been quite concerning. Some improvements, this is data from the United States, but we can see some improvements in the 2 to 5-year-old range, but the trends from adolescents are continuing upwards as well. And this is quite an interesting thing, as Chris spoke to. We actually, even if people appear to be normal weight according to the body mass index, and if people look at them, they appear to be normal weight. If we actually measure the percentage of body fat versus the percentage of muscle mass, what we actually see is that an awful lot of people have too much body fat. So in the medical literature, this is often termed as skinny fat, which is a kind of a paradoxical state. But this particular study, for example, looked at the prevalence of overfat. So what overfat means is having a high enough percentage of body fat relative to muscle mass that it actually would impact on our health. And if you look at that figure, 91% for adults and 69% for children. That's really quite amazing. And if you think about it, 91% of adults being overfat, so you're left with 9% of people who aren't. And within that group, of course, you have an interesting amount of people. Anorexia, for example, drug use, people who are bodybuilders, marathon runners. So we would really be talking about a small group of fairly exceptional people. Just to reinforce Chris's point, recent study of 4,000 people hospitalized with COVID in New York City during March. They found that the chronic condition with the strongest association with serious illness from COVID was obesity. Greater risk than cardiovascular or pulmonary disease. And they point out that, as Chris mentioned, that obesity is well recognized to be a pro-inflammatory condition due to the metabolic activity of the fat tissue. Okay, so that's kind of a little sense of the problem. I'll give you my take on it, and Chris can weigh in towards the end. Usually the idea of weight is put on to people, not enough motivation, not enough willpower, that sort of thing. I'm reading some very interesting books on habits these days. And this is a quote from one of the books, Atomic Habits. Motivation is overrated, environment is everything. So really what's happened is our environment has profoundly changed, and it just swamps individual choices with creating habits in an environment that leads to, people have described it as an obesogenic environment. So I don't know if people saw that Pixar movie of the future. Anyway, so we can focus on 4 causes of obesity. I'll give you a quick sense of them. How science, business, government, and our own biology are more or less colluded to create a situation where 91% of us roughly have too much body fat. I talked about this in previous webinars. You can check that out on YouTube. The pleasure trap. Really, we have a biological foundation that makes us highly attracted to food that through all of our evolution was extremely rare. We enjoy fat, sugar, we enjoy salt, and if we can have those taste experiences combined, really, we're not suited to turn it down, let's say. So our biology works against us. And take a look at the pleasure trap in previous webinar. And how does science collude with all this? Well, science is an amazing thing. We're trying to develop all kinds of approaches to heal all kinds of diseases, but at the same time, science is also being used to feed the same very diseases, which is kind of disappointing and ironic, I suppose. Several ways that happens. One is the development of bliss point foods. I did my PhD at the University of Guelph and Waterloo, and the University of Guelph is famous for its food science and animal science. And I knew many of these researchers in the food science department, for example. They get contracted by food companies. Myself, actually, I had the opportunity after I graduated to work for Kraft Foods in Philadelphia. I took a different direction in my life, but they actually talk about how do you combine fat, salt, and sugar to create foods that meet the perfect bliss point. If too much salt would be unpalatable, but if you get just the right amount, and if you combine it with the fat and the sugar and the right textures, we have irresistible foods. But also, irrespective of those kind of foods, which we can call ultra processed, there's really been a fundamental change in the nature of food. And I talked about chicken last time, and I'll show you another interesting picture of that. And then another way that science is harnessed is what people call neuromarketing, to really understand how our unconscious mind and our unconscious behaviors work, so that every aspect of marketing, the structure of the grocery store, your complete experience in the grocery store is manipulated to get you to buy products that are the most deleterious to your health, and at the same time, the most profitable for corporations. I hope you can see that picture, because it's worth seeing. I just dug this up yesterday. I thought it was quite interesting. This comes from scientists in Alberta who actually have continued to breed earlier types of chickens. Now, these aren't old pictures. These are pictures just taken recently, but these are the kind of chickens that people grew in the 50s, in the 70s, and there's a present day chicken. These are chickens of the same age, I think just 8 weeks. So you can see that the chicken in modern, the most up-to-date chicken as a result of animal science is in fact a highly obese animal. And I talked, it is quite striking, isn't it, to compare those pictures. I talked about this last time, and I won't go through it in detail now, but essentially what the researchers suggest is if we eat obesity, we will become obese. So is eating obesity causing obesity? And the answer, you can check that out in an earlier webinar, is clearly yes. So we have science working against us. We have our own biology working against us, but we also have our governments working against us. And how does our government work against us? Well, there's a lot of different ways. One is that they allow neuromarketing. They allow billions of dollars of advertisements to be directed at children and adults, of course, who are just as vulnerable, in truth be told. But another way is through subsidies. And if you dive deep into the literature, people have described how essentially fruits and vegetables become more expensive, and all kinds of foods that are not health promoting have become much cheaper. Notice, for example, how carbonated soft drinks have radically become cheap, inexpensive relative to fresh fruits and vegetables. And that is explained through essentially the government subsidy structure. I won't go through the details of it, but many people talk about junk food tax. What we really need to start off with is changing the subsidy structure. In fact, there's talk of bailing out some of the meat packing plants owned by, huge conglomerate corporations and some of the richest people in the States and Canada. That's just an example. So we have our own biology working against us. We have science working against us. We have government working against us. And finally, we have large corporations whose main job is to make profits. And profits are made not through selling broccoli and apples and lentils, but through selling highly processed foods. So we have a collusion of all these forces that essentially make us victims. But here's the thing. If you realize this, all of a sudden you have a choice that instead of being a victim of our environment, we can actually be an architect of our environment, and we can take a different direction. So I hope that you spread this information to others and get that message out. It's not an easy thing, but a few of us can begin to swim against the current and change the direction of at least our own individual choices, and hopefully create a bigger movement in society. Okay, so that's the problem. We're victims, but at the same time, how do we become architects of our own environment? I'll give you 4 basic things before we pass it back to Chris to give us his own insights in working with people. And myself, I've had over 20 years of experiencing what happens to people when they make these positive changes. One of the first changes is to think about shifting to more plant proteins. Here we can see a typical graph. There's a lot of this in the literature. So this is a typical body mass index of normal omnivorous person eats a typical kind of diet. They would have a body mass index of 28, which puts them in the overweight category on average. And as people move towards fish eating, to egg and dairy eating, and completely plant-based, you can see that the body weight decreases, with the most plant-based being, on average, actually having a body mass index about 23, which is pretty healthy. And actually, you can take the same data and you can deconstruct it with blood pressure, diabetes risk, many of these cardiovascular risk. You can see that same pattern. So that the more plant proteins that we include in our diet, and of course, as I've discussed in previous webinars, one of the most important things are the legumes. Second thing, many people become vegans, but they take the wrong direction with it. They often get called junk food vegans, turning this excuse me, there's an awful lot of highly processed foods that can still be considered vegan. And of course, many vegans enjoy their vegan chocolate cakes, which is not really the point. So the second important shift is towards whole foods instead of processed foods. And that would include things like choosing nuts and seeds instead of oils, whole grains instead of processed grains, fruit instead of fruit juice, and really dramatically reduce the added sugars. The average person consumes about 20% of their calories from added sugars. When you get it down below 1%, for example, you begin to see the rate of dental cavities disappears. And instead, of course, our society is interested in adding fluoride to water to try to reduce cavities in children. My approach would be to get rid of the added sugars in people's diets. Now, along that line, there's been a incessant debate about low-fat diets. It's the sugar or it's the fat, and this constant debate about is it the fat or is it the sugar or the carbs. In fact, it isn't just sugar these days people talk about, but it's the carbs. The obesity epidemic has really been driven by an extra 500 calories per day that the average person consumes. Where does that come from? Notice that a big chunk of it comes from added fats and oils, added more dairy fat. So fat is a huge contributor, but equal to it, if you add these two together, equal in magnitude almost, is the sugar and sweeteners and white flour and processed grains. So we basically have the carbs that people speak about, the bad carbs, and the oils. So the actual answer is we need to dramatically reduce added sugars, white flour, processed grains, and at the same time reduce the added fats and oils and highly fatty types of dairy products. And a perfect example we talked about in the last session was the ultra processed food versus the whole food. The perfect example was the plant-based burger versus an actual real bean burger, whether homemade or there are actual options of commercially available bean burgers. So the plant-based, so-called plant-based burger was highly processed isolated proteins, isolated fats with a bit of cardboard added in and flavoring versus something with real food. Third point, increase your nutrient density and lower the calorie density. So how do we do that? There's really great research from Barbara Rolls, a professor at the University of Pittsburgh, who's done a lot of research on calorie density. Essentially, people eat the same volume of food. And if you change the amount of calories in that volume, and as I say, that helps explain why chicken is an obesity promoting food, is because there's so many calories in the chicken now. 2.5 times the calories that chicken from 50 years ago had, in fact. So if we snack on low calorie density foods like fruits, we add vegetables, eat more legumes, our classic food with tons of fiber that really has a strong satiety effect. It has a lot of volume to it, but importantly, it has a lot of nutrients. We want to eat a lot of nutrients and less calories in the food to really begin to optimize our health. And I won't go into this in too much detail, but we'll turn it over to Chris in 1 second for some inspiration from him. And as I said, it's a difficult path because you are swimming against the current of our whole society and the whole environment that's set out to hijack us. And I hope people can share some experiences and some questions towards the end along that regard. But my 20 plus years, I found that various people, there can be other different tweaks on that basic first 3 strategies. Exercise, perhaps we can do a whole webinar on that, led by Chris, of course, who has great expertise in that whole area. glycemic index can be extremely important for some people. And what that means is that when you eat a carbohydrate food, if it really rapidly raises your blood sugar, in many people that will set off an overeating response and dramatically increase people's appetite. So for some people, they have to be very conscious of eating low glycemic foods. Timing of when people eat, and also taking time to not eat, it can both be quite important for other people. And lastly, I'll end with the fact that there's some really interesting research that shows how obesity is a socially contagious disease, if we want to call it a disease, which perhaps is a fair thing. Choose the right friends and family. Well, I guess we can't really choose our family, but if you, I've
God knows that's true, or I would have done a lot different.
So, yeah, if you really want to make a big difference in your weight, get in touch with Chris, join your local triathlon club, your local running club, that sort of thing. Hang out with people who are inclined to make different food choices, and that can probably make a big difference for many people. So anyway, with that said, it is a challenge. So perhaps I'll turn it back to Chris, and he can offer some insights and inspiration along that line too, to help us swim against the current.
Sure, I won't say much because hopefully people have some questions, but I'll start by using a little analogy. It's interesting over the years. One of the big things I do with patients, one of the obvious things that I have to deal with, I get somebody in with a terrible cough, and they've been a smoker for 40 years, and they have obviously really bad lungs, and so I'm constantly talking about smoking cessation with people, and I've noticed, I do various jobs, but in my work in the Emerge, I meet people, I have a serious talk about their smoking, they look really serious about quitting, and they usually tell me, well, I'm cutting down, and then I'll see them again 6 months later, they're even worse, and they say I'm cutting down, and I see them again a year after that, they're still cutting down. And my impression for years was that cutting down is not a very successful way to quit. If you actually want to quit, you just have to quit. It doesn't matter if you're smoking 4 packs a day, just quit is the best way to quit. And it's interesting because that's been backed up recently by a number of studies which show that trying to cut down on cigarettes, all it does is drive you nuts, because when you're used to smoking 30 cigarettes a day and you try to smoke 10 a day, all you do is you want 20 more cigarettes a day, and it drives you crazy. And as you try to cut down over several months, you go crazy for months and months. Whereas if you just quit, you go crazy for a few weeks after you quit, and you're a bear, and you're cranky, and you're nasty, and you're eating everything in the house, and then it kind of passes bit by bit by bit, and you get over it. And the entire period of discomfort is much less if you just go ahead and quit and go to zero right away. I think there's a real analogy with eating in that. If you try to just make some little tweaks and eat less of the chocolate and less of the sweets and less of this and that, your body maintains the taste for it. And Mike talked about that with the pleasure trap issue earlier. You can reset your taste, you can reset your brain, but it's important to just make a big change and do it all at once. I do want to, I'll give you a little bit of inspiration. I have a good friend who, when I first met him, he did one of the ancillary jobs at the hospital. When I first met him, he weighed 335 pounds. And he was, he has a sedentary job, sitting at a computer like many of us. He weighed 335 pounds. He ate about 5 times a week at McDonald's. When he did eat at home, it was not good food. He didn't do any exercise. He was in his early 30s, and he had a family doctor who's notoriously, and not me in this case, but who's a family doctor who's notoriously blunt. And he wasn't feeling well, so his family doctor did a bunch of blood work. He went back to his family doctor a week later to get the results. The family doctor looked him right in the eye and said, your sugar is borderline, your blood pressure is terrible, your cholesterol is high, you are 150 pounds over your ideal body weight. He said, I can start to put you on pills for all these things. And he said, from my experience, I can tell you, you're going to end up on 4, 5, 6, 7, 10 pills over the next 10 or 15 years, and you're still going to die young despite all that. He said, so you got to go home and make some decisions right now. Either I start putting you on pills or you make a big change yourself. And he went home and looked at himself in the mirror, and then this is his words. He said, I looked at myself, I saw this big fat tub of goo, and I thought, what the hell am I doing with my life? And he made these massive changes. He had a friend at work, again, not me, a friend at work who was a runner. And this guy was a small guy, weighed 140 pounds. And he joked that his goal when he started out, he made a goal with his friend. He said, I want to lose one of you. He said, I wanted to lose a Steve worth of weight. He wanted to lose 140 pounds. And Steve took him out running a few times, which was more like, he called it, my friend called it a waddle. And he would only do it after dark so nobody would see him. And he made big changes to his diet, and he lost 10 pounds in the first week. He lost 20 pounds in the first few weeks. He kept losing weight. Now he actually weighs slightly less than me. He weighs about 180 pounds. He's completed an Ironman race. And this is, he made these changes about 15 years ago. So this is not like a flash in the pan and he's going to be fat again. He's maintained this. He feels great. He looks great. He's changed his life in a lot of good ways. So it's very possible. And I do see these stories. There's this kind of fatalistic attitude that a lot of people have that, well, you know, my whole family's fat. Well, you know, it's just in my genes. It's easy for you because you're thin. You wouldn't understand all this. What I can tell you is that this guy's whole family is also fat, but we inherit our propensity to be fat not through our genes. Genes are probably account for 2%, 3% of the people's tendency to be obese. When you look at the research, it's our habits that we mainly inherit from our parents. If our parents eat at McDonald's 5 times a week, we think that's normal. We do that too. So we inherit our habits as well as our genes. So anyway, just that to say that it's not only possible to make these changes, but lots of people do them. We just tend to hear from people who are negative on that whole thing. And a lot of doctors, unfortunately, are negative because most people won't make the big changes. So doctors tend to get negative and cynical. I'm not. I think it's very possible. And I know that many people who are logged on here have already made those changes, but I hope you can go and proselytize to your friends to make the same changes.
Thanks, Chris. Yeah, in my experience, I would agree with you 100%. A lot of times that I will see people who visited dietitians who suggest to people to make baby steps, and the baby steps lead nowhere, and people just give up and blame it on their genes. But if they can make really big changes and they see big results, then they can get very much inspired to stick with it. And as you say about genes, I think it's extremely important for people to realize that there's something called epigenetics, that when we eat unhealthful food, it actually changes the way our genes work. And the opposite is true. If we choose very healthy foods, part of the reason that our health dramatically improves so quickly is through epigenetic effects that the way people's genes work actually can change in a matter of weeks. And in fact, Dr. Dean Ornish, in his research in reversing early stage prostate cancer, showed that in 3 months, 500 genes were changed in how they worked just by changing how people ate, exercising, meditation, group support. A whole combination of those things resulted in 500 genes actually changing.
Mike, I just wanted to shift. I noticed I popped up the Zoom chat, and there's a question there that I think I can hopefully answer well, that Nancy had put up. Beautiful. And maybe I can address that. So the question from Nancy, if the other folks, you can either put up your chat or I can read it, but she says, is there a fat roll pinch test as a general way to determine BMI at home? And then I noticed Kale said to everyone, BMI is measured as weight to height by gender. maybe you're thinking of body fat percentage. So those are great questions. And so the first thing I'll tell people is, in a practical sense, trying to measure body fat percentage is really, really, really difficult. The only accurate way is to kill the person and render their body down in a tub and measure the amount of fat you get out of it. And there's not many volunteers for those types of studies. So that's not a very practical way to do it. There's also these dunk tests where they take you and they measure your weight normally on a scale, and then they put you in water, underwater, and measure you again underwater. And they kind of, it measures your buoyancy, and they can estimate a body fat percentage from that. But even that's not accurate, because that still depends on things like the density of your organs, your bones, and other things, which vary from person to person. So there's this degree of inaccuracy even in these more complex tests. So in practice, it's fairly difficult to measure body fat percentage. And the happy thing about all that is it's not all that important. BMI as well it's probably a decent indicator. But one of my favorite things, I wish I could pop it up here, one of my favorite cartoons, there's this picture of this, it's a Herman cartoon. Herman's one of my favorites, but it's this big fat doctor sitting at a desk, and he's got a patient who's really fat on this really complex looking scale with all these computers and whatnot. And the patient's obviously morbidly obese. And he said, the caption is, "My Weightinator 5000 tells me that you may have a problem with your body weight," you know? So I always joke, for anybody whose body weight is a problem, it's almost never a mystery. And so all these concerns about measuring body fat and whatnot, they're perhaps practically important if you're about to do an Olympic marathon, or you're a hockey player or something. They're measuring your fitness very, very closely. But for most of us average public, it's not that important. Even BMI is not a great measure, because you can get somebody, if you're an Olympic weightlifter, your BMI is probably going to be in the 30 to 35 range, and you may have a really low body fat percentage. You're one of the fittest athletes in the world, but you have a high BMI. And on the other end of the scale, I see people who have really low BMIs, but they have really low BMIs because they smoke like chimneys and they do crack cocaine, and that's not a healthy way to achieve that. So BMI is just one measure. Body fat is very hard to measure. So these things in practice are not that important. One thing that always comes home to me, there's been research study after research study that says we can measure BMI, we can try to measure body fat percentage, we can measure cholesterol levels, we can measure blood pressure and all these things, and they all predict death somewhat. But we can have people with really good cholesterols who drop dead of heart attacks. One of the best tests to see if you're healthy and if you're going to drop dead in the next year or two is go out, and if you're 70 plus, walk around the block twice as fast as you can and see how you feel. If you're 50 and under or 60 and under, you should be able to run around the block a couple of times and see how you feel. And if you can do that well, you're probably doing pretty well. And if you can't do that, then you have a problem, whether your BMI is high or low, or whether your body fat percentage is high or low. So fitness tests are one of the most accurate ways of stratifying risks.
Thanks, Chris. That's helpful. Any other questions there? I can't actually see the chat myself. Maybe Nancy can break in and tell us if there's any other questions.
Hi, I'm here. No, there was just the one from Russell and I. And then I did ask, just to clarify, so if you do have extra fat, then you're producing hormones. And so is that really, what's the indicator there for like women who are menopausal, or how does that affect them?
Yeah, so one of the things to remember too, and sometimes we lose this nuance, is that it's actually really unhealthy to have really, really, really low amounts of body fat. So the only people who end up with super low amounts of body fat are, number one, perhaps super fit marathon runners, and 1 mile runners are actually even skinnier than marathon runners, because marathon runners need fat stores to be able to run through a whole marathon. So some some very high-end athletes who are probably 1 in 1,000 or less of the population. But the other people who have really low body fat percentages are anorexics, drug addicts who aren't eating well, things like that. So there is this healthy amount of body fat, and it varies. Like for a male, it's sort of 8%, something like that, give or take a few percent. And for females, I believe it's sort of 12%, give or take a few percent. So that's a normal, healthy amount of body fat. And so some fat and some hormonal production is normal and necessary and actually runs your body in a healthy way. So you don't want to think about trying to reduce that fat down near zero. That's actually a bad thing. It's just about when you get unhealthy amounts of fats, that your hormonal balance is tipped, and those unhealthy amount of fats will do things like cause extra fat to store in your liver and cause fatty liver disease and damage. It'll cause extra amounts of cholesterol and unhealthy fats that circulate in your blood and coat the endothelium, coat the inside of the blood vessels and clog your blood vessels over the years. It'll produce hormones that cause your blood pressure to go up. There's all these different things. So it's the unhealthy amounts of fat which are problematic. And it's hard to measure directly the amount of fat, but for most of us where it's a problem, again, it's not a mystery for most of us where it's a problem. But if you're eating well, if your waist to hip ratio is decent, if your BMI is somewhere near decent, and you can go out and exercise at a decent level and you feel good, those are all good signs that you're doing the right thing.
Yeah, in fact, I would also add that I think for most people, it's not particularly helpful to focus on body fat. It's better to have other kind of goals, fitness, and even things like blood pressure, cholesterol, and take your mind off body fat itself. Because once you get into that zone of healthful eating, healthful lifestyle, you'll look great. Your friends will tell you you look great. You don't need to weigh yourself and really pay too close attention to your weight in most cases. Any further questions, Nancy?
No, I'm not seeing anything else there. You guys are pretty thorough.
Excellent.
Any comments from anyone? Anyone want to add anything?
Not seeing
Chris.
any. Oh.
Chris, I was reading something about obesity and COVID-19. They say that the fat cells harbor a lot of ACE2 molecules, and that the virus can be retained within the fat cells a lot longer than the rest of the body. Are you familiar with that?
I am. I've read about that, and I think the problem with this disease and why there's so much argumentation online about should we lock down, should we not lock down, what should we do exactly about it, how should people get treated, should we use hydroxychloroquine, shouldn't we? The problem with it is that we're so early in our understanding of this, and there's all these models which show this thing. And just for people who aren't as up as my Uncle Eric on this, ACE, angiotensin converting enzyme, is an enzyme that kind of controls your kidney function and your blood pressure. And it's one of the common drugs we use to control blood pressure are called ACE inhibitors. They block this this enzyme and prevent it from working as rapidly in the body. So anyway, that's what this is all about. And there are people who are obese. Yeah, they have more of these receptors, which may kind of be related to susceptibility to severe disease from this particular virus. But I don't think enough is really known yet to say whether that's a big issue, whether it's a small issue, whether it's a medium-sized issue, whether it's not an issue at all. It's a good theory, and I think it's going to pan out. And I think a year or two from now, when we know more about this, we're going to look back and say, yeah, that's probably the cause. To me, it's really interesting because it's interesting scientifically, but in terms of its importance to a practical day-to-day life, we know for sure that being obese and having all these other risk factors that Mike mentioned at the beginning are important. So whether it's because of the ACE receptors or whether it's something different, I still think the basic messages hold. But I do think it's a really interesting line of scientific inquiry, and it's being looked into very, very heavily right now.
Great, thanks.
Thanks for the question, Eric. Any further questions before I get to the best part of the whole session, which is the recipe of the day? Any further questions, Nancy?
No, I'm not seeing anything.
Okay, great recipe. I just made it last night. I'm quite excited about it. I actually, this is a omelet, and it's made with chickpea flour instead of eggs. I'd highly recommend giving this a try. Just the history, I used to make a chickpea flour omelet from Dr. Esselstyn's cookbook, well, actually his wife and his daughter's cookbook. Anne and Jane Esselstyn, I'd highly recommend that cookbook. But it had a lot of nutritional yeast in it, the Esselstyn recipe. And we had certain people in my household, not mentioning any names, who found it not too palatable. Others liked it, so there was a bit of debate about it. And I just saw this version from Dr. Joel Furman a couple days ago, and I thought I'd give it a try, convince the fussy people in my household to give it a try. And it was a big hit, big hit. Lots of vegetables, really great taste with a lot of herbs, and it was just very digestible. It felt really light and filling, but light at the same time on the stomach, and just super nutrition, packed with 3 cups of kale. And you can't go wrong when you have 3 cups of chopped kale in a recipe, that's for sure. You get your quota of green leafy vegetables. And I'll send this recipe out to everybody. Give it a try, and please let me know how you do. I've made some adaptations to it from Dr. Furman. I might make a few more, and when I make enough changes, I'll call it Mike's Vegetable Omelet instead of Dr. Furman's. Anyway, please give it a try. Give me some feedback, how it works out, any suggestions you have. Part of the key with any of these recipes is the flavoring. In this case, I changed it to oregano and thyme, and it has turmeric in it as well. So you get the herbs and the turmeric. And the only other thing I'll mention is it's a little tricky you want to cook without oil. And the trick is to get the pan so that it doesn't stick. And if you have a non-stick pan, that would be ideal. Otherwise, yeah, you might need to coat it with the tiniest little bit of oil. Anyway, let me know how that works out for you. I'm still trying to get that sorted in my own kitchen. So great recipe though.
Mike, I'm going to go back to something, because Nancy asked a good question that I kind of skipped over in the beginning of all this. Why was COVID so high in Italy versus here? And I think that's really, the reason I think it's important is, again, I felt part of my public service in the last month or so, as our numbers have become more apparent, is to calm everybody down about COVID, because there's so much hysteria. And I think, truthfully, the hysteria and the lockdown, I've seen that's killing more people than the actual COVID virus itself. So it's a great question, Nancy, and I think I can answer it hopefully well. So there's a few factors. So number one, I do think sort of the cultural habits of Italy were probably part of why it spread so quickly. Italy, everybody sits very close. There's not much personal space. When you see somebody, you kiss on the cheeks. So it's the ultimate social environment for this bug to spread rapidly. You compare that to Japan, Taiwan, some of the other countries, which actually had COVID introduced earlier than Italy, but they didn't spread nearly as quickly. So I think that's undoubtedly part of why it spread like wildfire. But why did it appear so terrible in Italy? Well, the first thing I want to dispel, so what you saw on the news was the worst 1% of what happened in Italy. So there was talk about how, 60-year-old people were not getting ventilators because everything was so bad. The emergency medical grapevine is very small. So a good friend of mine has a couple of friends who work in Italy, and he was in touch with them, and he was saying, is it really this bad? And they said, it's really bad, but that kind of thing never happened. What happened was, we make decisions every day up the emergency room. So if somebody comes in and they're 64 years old and they have a lung cancer and they have terrible lungs from smoking their whole life and they're diabetic and this and that, and they come in with a terrible pneumonia, we kind of talk to the family and say, look, we could put this person on a ventilator, but they're not going to make it. They're going to be on the ventilator for 2 weeks. They're going to suffer like hell, and then they're going to die. So we should just let them pass comfortably. So that kind of decision where we take somebody in their 50s or 60s or even younger with certain types of health problems and make a decision not to put them on life support, it happens all the time. That kind of thing was happening in Italy, and they had to be more aggressive about that, because sometimes we do get talked into, well, I want them on a ventilator anyway, and we do it. But Italy, they were really tight and they were short, so they had to be a little more aggressive about saying, look, this person's not going to do well, we just can't do that right now. But then the people will go to the press and say, oh, my dad was only 61, they wouldn't put him on a ventilator. And because of medical confidentiality, no doctor could then go to the press and say, wait, that's not the right story. This guy, had this and that and that and that. We chose not to put him on a ventilator, not because we didn't have room, but because he was too sick to do that. It wouldn't have been fair to him. So that kind of thing got misrepresented in the news. The other thing that really got misrepresented was the deadliness of the disease. So now that we've had some time to see things play out in Italy, Italy's at about 30,000 deaths over 2.5 months. That sounds like a lot of deaths, and it is. But the average number of deaths in 2.5 months in Italy is like 140,000. So it's a big country, and a lot of people die. People get old, people die of various things. So it's 30,000 extra deaths on 140,000. Plus, a lot of the people who died out of that 30,000 were people who would have died in these few months anyway. So it's not 30,000 extra deaths. So we'll only know in another year or two how many extra deaths there actually was. But it's not like the death rate doubled in Italy. The population of Italy was still going up during all this time. There were more babies being born than were dying. So it's not like the Black Plague where everybody was dying. The final thing that is important to know, these estimated rates of death were around 12%, but it turns out, again, this was known by the medical people, but it didn't make it to the press. But because there's a limited amount of testing, they only had X number of coronavirus tests available. And so people who were a little bit ill who came to the hospital, but were well enough to go home, they didn't test them. They just said, well, you go home, just stay home. If things get worse, come back. So they only tested the people who were really, really sick and needed to come into hospital. So the correct statement was, out of the people who were sick enough to be hospitalized with coronavirus, about 12% of them died. But since then, we know that somewhere from 30 to 50 times as many people as got tested actually had coronavirus. So if you take the 12% and you divide it by 30, you end up with 0.4% death rate, which is more towards what we kind of know that it is now. And that's more in keeping with what we're seeing in Nova Scotia and Ontario and everywhere else where we're doing a better job of testing more people. We're still not testing everybody. So the number of people, when you see that there's 1,000 positive tests in Nova Scotia, there's probably at least 2 or 3 times as many people who've had coronavirus, but it's not 50 times in Nova Scotia. So our death rates are actually quite low, and they're more in keeping. We have 44 out of 1,000 people who've died. And if you multiply the fact that we've missed a bunch of people who've actually had it, and then you take the death percentage, it's going to be less. The estimates are definitely less than 1%. So it's much, much less deadly than it first seemed to be in Italy. So anyway, I hope that's helpful. If you have any more questions, feel free.
Thanks for clarifying that, Chris. Any final questions before I give the final words?
Well, I just asked if there was less testing going on in Cape Breton versus Nova Scotia. Is that affecting while we're just seeing that there's no increase here because we're not testing?
Great question. So yeah, if people, you can go online. The Nova Scotia government has all these numbers online, but there's out of the 1,000 cases in Nova Scotia that have been known, and only I think it's less than 200 of those are active right now. So most of those have gotten better. A small percentage have died, but only 50 of the 1,000 cases are in the eastern zone, so Landing and Ishon up, and we haven't had a new case unless we had some today, which I didn't look at, but we haven't had a new case in well over a week. So we're actually down to 0 active cases in the eastern zone right now. I don't think that represents less testing, although we have done less testing just because less people have come to the hospitals and assessment clinics with cough, colds, fevers, flu-like illnesses to get tested. We've done less testing, but it's not because the government's doesn't want to do as many tests here. We had availability to do way more tests than we did. We just didn't get that many sick people coming in, so we didn't do that many tests. So I think there's undoubtedly way less coronavirus per capita in the eastern zone, in the northern zone and Amherst area, whatnot, in the western zone out in Yarmouth than there was in HRM. Almost all, I think it's 800 and some cases, 850 cases out of 1,000 are in the HRM area. So there's these clusters of people. So yes, there's less testing, but there's definitely way less disease. And I think we're probably down to 0 cases. So unless somebody travels here directly from Halifax these days, you can safely, you don't have to walk the other side of the road and pull your scarf up around your mouth. I still wouldn't go and kiss random people in the street yet, both for social inappropriateness reasons. And I suppose you want to still be careful about COVID as well.
Okay, thanks, Chris. Well, I think we should call it a day. Just once again, I'll put this up on YouTube. Please share the presentation with your friends and family. Some really great information today that I think is extremely important for people. And thanks to Chris so much for joining us today. And thanks also to you too, Nancy. And tune in to next week's webinar. And I don't have a topic yet, so please feel free to get back to me. Let me know any feedback you have and suggestions for future sessions. And also make sure you get into the kitchen and cook up a storm. So thanks so much, everybody, for joining us, and hope to see you next week.